Good morning, everyone. Welcome to the eighth case in the Upload Radiology case series. This is an axial cardiac CT of images of this patient. Here we are able to see the main pulmonary artery and its branches are dilated. The left coronary artery is dilated with normal distal caliber of the LAD and LCS, and it runs as a tract entering into the right atrium. Here we are able to see the entry to the right atrium better. Pulmonary artery hypertension, left coronary artery aneurysm. The contrast difference, the septum is well maintained. Here it is open. So this is a point of entry into the right atrium and the right ventricle. So to summarize the finding, this patient had a dilated left coronary artery which communicates through a fistulous tract into the right atrium. The right ventricle is dilated and pulmonary artery and its branches are dilated. Distal to the fistulous tract, there is a normal caliber of the LAD and L6 branches. There is no other congenital anomalies. So this is a case of isolated coronary cameral fistula, Sakakibara type A, which basically means there is a fistulous communication between the proximal part of the left coronary, and in the Sakakibara type B, it is between the distal branches of the left coronary. And it is a single fistula communication, as we saw in the images, with associated right ventricular hypertrophy and pulmonary artery hypertension. So these are the catheter images. Here we can see this is a dilated coronary. We can see the normal caliber of the right coronary here. Dilated left coronary, which goes and joins the right atrium. We can appreciate that compared to the catheter angio, the cardiac CT images were better as far as the revelation of the anatomy and morphology of this patient. This again in the AP view, you can again see that the patient is having a dilated left coronary which enters into the right atrium. This better depicts the pathway in which the left coronary and the fistulous tract is seen. This is a tract entering into the right atrium and into the right ventricular outflow tract and the pulmonary artery. One better use of the catheter angio is that we'll be able to see the entire course when we use a microwire and a micro catheter combination to depict the pathway. So coming to the discussion, this is an excellent article that I saw in the net about coronary artery fissulas, pathophysiology, imaging findings, and management. There are a few important things that I would like to discuss about it. One thing is whether cardiac CT or catheter angio needs to be done in a suspected case of coronary artery fistula. As we saw in the previous images, the CT angiogram is excellent as far as 3D multiplanar imaging and anatomical information is concerned. When compared to an invasive angiography, when compared to a conventional angiography, this is better because it is just a two-dimensional fluoroscopic images that we are able to see in the catheter angio. But if you're planning to intervene, which should be the last stage of any evaluation, then catheter angiogram is better. For all practical purposes, the first and foremost evaluation should be done using cardiac CT. Coming to the classification of coronary artery fistula, It can be classified based on etiology, congenital, where it is embryonic in nature, or acquired, which can be because of iatrogenic causes, trauma-related, radiation injury, or disease-related. Based on the coronary artificial origin, it can be the right coronary artery, LCA and RCA, or other anomalous coronary arteries. Based on the segment, which we already saw, type A or type B. Type A if it is originating from the proximal native vessel, B if it is originating from the distal native vessel. Here the distal artery is normal, whereas here the distal artery, entire artery is dilated. Drainage side. Based on the drainage side, coronary artery fistulas can be either coronary cameral fistula, in which it drains into a cardiac chamber. Chamber is basically cameral. And it can be coronary artery fistula, where arteriovenous fistula, where it communicates with one of the arteries or veins around the heart, which could be either the pulmonary artery, coronary sinus, supine inferior cava, pulmonary arteries, or the extracardiac veins. Can also be based on the fistulas, number of fistulas. Either it can be single as in our case, or it can be multiple, which we'll see in the typical images which we follow, or based on the morphology and complexity. This is more important as far as intervention is concerned, whether it is an entangled mesh of vessels, if there is any stenosis or any ectasia or multifocal aneurysms. The complexity of the fistula divides it into simple or complex coronary artery fistulas. And lastly, whether there is any accompanying cardiac anomalies. If isolated CAF, when there is no accompanying anomaly. If sometimes you might see congenital heart disease like a VSD, PTA, tetralogy of Fallot, and other valvular diseases. So this is a pictorial representation. Here we are able to see there's a coronary artery fistula which originates from the right coronary artery and drains into the right ventricle. Here we are able to see it is originating from the right coronary, enters into the right atrium. Here it is going and joining the pulmonary artery, and here it is going and joining the coronary sinus. Here it is going and joining the middle cardiac vein. Here it is going and joining the bronchial artery. So here the communication is between the obtuse marginal branch of the right coronary artery and the left ventricle. Here there's another patient in which there's a communication between the left coronary LAD segment and the pulmonary artery, which is better depicted in the catheter angio also. Sometimes we'll be able to see multiple small fistulas which is originating from the right coronary artery and goes and joins the pulmonary artery. So the communication with the pulmonary artery can either be single fistula as of the previous case, or it can be multiple fistulas. When it is multiple fistulas, you'll be able to see a bunch of vessels at the aortic root, like this. Small vessels. This is a post-coiling image of the same patient. Cardiac beat. So this is the coronary artery fistula which is going and joining the middle cardiac vein. This is a site of communication. This is a 3D image in which we are able to see the artery fistula as well as the dilated coronary vein. It can be between the left coronary artery and the bronchial artery. Here we are able to see that it goes and joins the bronchial arteries. This most commonly occurs in case of extensive bronchiectasis of the bilateral lungs, where it takes feeders not only from the bronchial arteries, also from the coronary arteries, esophageal arteries, lima. So that is when we see these kinds of fistulas. Coming to what are the things that we have to report. So there is a pre-procedure before surgery and post-surgery. Pre-surgery, we need to talk about the number and location of the fistula origins, where exactly they are draining, the exact course and size. This is better depicted on the console by showing it to the surgeon directly. And the fistula complexity, is there an angulation, whether there's a tortuosity, whether there's a stenosis, and whether there are other associated congenital anomalies. Post-procedure, whether there is any residual leakage or recanalization, any aneurysmal change, or is it persistent dilatation, thrombus which is seen in the aneurysm, coil or device migration, myocardial ischemia, complications of the coronary artery fistula, any dissection and perforation. Here we are able to see this is a coronary artery fistula which is going and joining the right atrium. Post-procedure, after excision, we are able to see it is of normal caliber with the normal caliber of the distal branches. Coming to the important differential diagnosis, there's three important differential diagnoses. The most common which we see in day-to-day life is ectasia secondary to atherosclerosis. Here it is just a mild dilatation that we are going to see. It is not like a severe or moderate kind of a dilatation. And again, we see stigma of atherosclerosis which is present. And the patient will have a coronary artery calcification and other features which is suggesting atherosclerosis. Second most common is vasculitis, which can either be Kawasaki disease or Takaisa's arthritis. The profile is different. Kawasaki it is in children and it's a medium vessel vasculitis. Takaisa's it's in adults and large vessel vasculitis. So based on the clinical profile, we'll have some amount of clue that it's the vasculitis we are dealing with. Imaging wise, how do we differentiate? If it is a normal origin without any dilatation at the ostia, then it is more likely because of vasculitis rather than a fistula. Second thing is it's just a dilatation that we see and we never see a fistula. It can show irregularity, stenosis, and ectasia. Coming to the last, which is Al-Kappa, anomalous origin of the left coronary artery from the pulmonary artery. It usually originates from the main pulmonary artery. It is of two types, adult or infantile type. Adult type will have collaterals because it has been lasting for a long time. The patient will be able to develop some collaterals to overcome the situation. To summarize, most of the coronary artery fistulas will be asymptomatic. If they are asymptomatic, it will be because of right heart failure. Just in our patient where we saw that was right ventricular hypertrophy, pulmonary artery hypertension. Sometimes there will be myocardial ischemia when there is left ventricular hypertrophy and there is steal of blood from the coronary artery. Arrhythmias, infected endocarditis, and this could be a source of thrombosis and multiple infarcts. And so if it is symptomatic, it has to be treated. All fistulas which are large in size, single fistula, there is a class 1 recommendation for them to be treated. If it is asymptomatic, you can still just wait and watch. And second thing is the drainage site of coronary artery fistula is more important rather than the origin, because a shunt to the low pressure system can dilate the coronary arteries and lead to aneurysm formation. And aneurysm formation can have a prognosis of impending rupture. Second thing is depending upon the drainage site, either it can be to the right heart or the left heart. Depending on it, the patient can either have a right heart failure or a left heart failure.